I appreciate the opportunity to discuss optimal left ventricular lead location and outcomes with cardiac resynchronization therapy. I'm Brian Powell. I'm an electrophysiologist at Mayo Clinic. And these are my disclosures. Each day when we implant cardiac resynchronization devices, we have the option of where to put the left ventricular lead. And most patients have more than one vessel that can be selected, so we usually use some type of guidance from the literature to help us decide where to put the lead. The image shown here shows the different segments of the left ventricle as will be used in most of the trials that I'll discuss. Basically, in the RAO view, it divides it into thirds with the base, mid, and apex of the left ventricle. And then the LAO view is divided into the anterior, lateral, and then termed either posterior or inferior segment of the left ventricle. Originally, back in 1999 and 2001, a couple of important studies showed that if you pace the lateral wall of the left ventricle, the patient is more likely to have acute hemodynamic response compared to pacing the anterior wall of the left ventricle. And then more recently, Dr. Delnoy and colleagues found that with different patients, different sites had improved acute hemodynamic response to cardiac resynchronization. In the majority of patients, either the lateral wall or the posterior wall created the most benefit. But notice that in about 10% of patients, the anterior wall was the most effective site for acutely improving maximal DPDT. And in a small percentage of patients, the right ventricular apex was actually the most effective site. So there is some patient variability, but most patients, the lateral wall or posterior wall is most effective. The companion trial is the largest trial to look at lead position. Dr. Saxon and colleagues looked at more than 1,500 patients retrospectively and compared the various lead positions to optimal medical therapy. Patients with an anterior lead position had a slightly decreased 6-minute walk improvement compared to the other groups. But overall, when you look at all the clinical endpoints, there wasn't a significant difference from an anterior location versus posterior or lateral wall location. And their conclusion was that the results were relatively similar in this non-randomized study. And Dr. Kronberg and colleagues looked back at several hundred patients in a similar manner and compared patients with a laterally placed LV lead to those with leads placed elsewhere, including the anterior, inferior, and the apex. And once they adjusted for patient baseline comorbidities, they found there was no significant difference whether the lead was placed in a lateral position or elsewhere. There was no significant difference in survival, heart failure class, or improvement in EF, as we see in the right-hand column p-values there. My colleagues, Dr. Dong and Dr. Cha, looked at our experience at Mayo Clinic and found that patients with a lateral or anterolateral lead position had improved survival compared to patients who had the lead placed in an anterior interventricular vein or middle cardiac vein. So, at least in this retrospective analysis, it appeared that a lateral lead position was associated with improved survival. We looked in more detail at a subgroup of a little bit more than 100 patients and found that when you break down into smaller segments and look at not just anterior, lateral, but also base, mid, or apical position, there were similar outcomes except for the group that had the lead out very apical. Those that had the lead out in the lateral LV apex had decreased response rates to CRT. Another study had the same findings with Dr. Merchant and colleagues. They also found that apically placed leads were associated with decreased survival free from death or heart failure hospitalization compared to LV leads that were placed in the base or mid left ventricle. So we looked at several retrospective studies trying to help us predict where to best place the lead. Can we tailor where we position the lead on an individual basis? Well, that was the idea behind looking at echo dyssynchrony. We know that tissue velocity and other parameters of echo dyssynchrony have been investigated to see if it will help determine which patients are most likely to benefit from CRT. But can we also look at this to help to determine where to place the left ventricular lead? With tissue velocity, we can determine where's the segment with the greatest time to peak delay. Dr. Fung and colleagues looked at the concordance between the segment of greatest delay by tissue velocity and where the left ventricular lead was placed. These leads were placed at the discretion of the operator and were not guided by echo. They looked back retrospectively and found that the patients who had concordant LV lead location with the area of greatest delay did not have any better outcomes compared to those with discordant LV lead positions relative to the segment with greatest delay by tissue velocity. Echo strain is looking at the time to maximum shortening of a given segment in the left ventricle. It has some benefits that overcome some of the tethering effects that limit tissue velocity assessment of the segment of greatest delay. And when this was looked at in a couple different studies, it is found that when the LV lead was concordant with the area of greatest delay by strain, that patients had decreased adverse outcomes such as death and heart failure hospitalizations compared to patients with discordant LV lead positions. So this suggests that strain may be of better benefit in predicting where we should put the left ventricular lead. Because there was some discrepancy in the literature, we looked at our own data and looked at both strain and tissue velocity. And in the patients who had their leads placed in the segment that was close to the area of greatest delay by strain, there was a greater response to CRT compared to patients whose leads were not in the area of greatest delay by strain. On the other hand, when we used tissue velocity, there was a significant difference. The area of greatest delay by tissue velocity did not correlate well with the left ventricular lead position that was optimal. So in conclusion, what message can we take home from all these trials? The majority of trials suggest that a lateral lead position will result in improved outcomes. And in particular, the lateral lead position at either the base or mid-left ventricle. We have a couple trials now showing that an apical position is associated with adverse outcomes. If the lateral lead position is not possible, either due to diaphragmatic stimulation or other factors, then anterior or posterior positions are second best options. In the future, we may be able to use echo to help guide which area of the ventricle has the greatest delay and target our lead position based on that echo guidance. So I'll conclude there and I appreciate your attention.